Morning, and thanks for the few people who got up on Sunday morning and came. Uh, my first job is to invite you for our meeting. It's on 29th August, and something. What happened? When the audio went down. It's okay. They can understand. They can hear. It's okay. So let us please. No problem. Thanks. Yeah. No problem. We go ahead. Okay. My job today is current trends in the reconstructive surgery for POP. Uterus sparing. What? Uterus sparing versus hysterectomy at the time of prolapse repair. It's a rather complex topic. Initially, I thought only the second part was my talk. Then I realized the first part also has to be part of the talk. So I've added both together, and I've got a sort of Chennai mixture going for you. So the outline of my talk is basically we'll go through the prolapse scenario, some progress we have made in prolapse repair, go into why hysterectomy was being done, and the dilemma, hysterectomy versus save the uterus at prolapse repair. So the father figures, Fothergill, Donald, all these people, basically did not have the luxury of these lovely MRIs, pictures which we get now to decide and diagnose. But the normal position of the uterus, even yesterday we were emphasizing that that position is important to keep that uterus in position, in the correct place. Now, if it gets erect or if it gets retroverted, the chances of it slipping down are high. So this was the basic concept with which they were handling prolapse right at the beginning. So what was happening is all the initial attempts to repair prolapse, the historic parts, were to just narrow down the vaginal canal. You'll understand it very simple. Once you narrow the vagina, prolapse they think will not come out. But given time, even in that, through those little holes, prolapse will come out. Then in the 20th century, Manchester Fothergill procedure to amputate the cervix with all its accompaniments. You're all familiar with it? I don't. The other techniques which you wouldn't have heard so much was Schauter, Wertheim's and Watkins' technique, where they basically folded the uterus and attached the uterus to near the anterior vaginal wall and thereby prevented its descent. So this was the concept with which it was working. But today we have much, much better gadgetry to help us. 3D may change our understanding. Traditionally, we have thought the cardinal ligaments go like this and the uterosacral ligaments go down. But if you see the 3D orientation, the picture is like this. You can see that the cardinal ligaments go up, and you can see that the uterosacrals go laterally to support the thing. Further improvement in the support theory comes up if you can do an entity called dynamic MRI, where you have the H line and the M line to tell you the levels. Because these were all just imaginary vaginal examination, thinking of where the spine is, where that point is, and deciding. Then the only other option we had was to take a plain X-ray to decide. But today, the dynamic MRI, the H line and the M line, tell you exactly where the level of the uterus is. It also tries to create that apical point. Now you will realize as you do more and more prolapse repair, that if you can get that apical point up, the rest of the repair today is secondary. Your cystocele repair, rectocele, everything will go off if you get that apex up. So concepts are changing on that and may work. I know most of you don't like PopQ, but we don't have any choice. That's still the best option. There is a small app to score PopQ in case you're very hesitant to remember the numbers. And also, there's the poor man's simplified PopQ. I can't say Aam Aadmi because we have the lady sitting here. Okay. Stage 1, Stage 2, Stage 3, Stage 4, which is very, very simple. Level of the hymen, below the hymen, and then you have the procedentia. So once we have organized it, I just thought I'll take you briefly through what many Indian authors have done to repair prolapse, but most of these were essentially for nulliparous prolapse, because you'll remember in world literature there's very, very little material on nulliparous prolapse. They don't see it very much. You can see for Shirodkar, he would take a ring from the sacral promontory to the back of the uterus, right round, and he would take that loop to prevent the sigmoid colon from getting jammed. Then we had Purandare sling, where he would get it from the fascia. Initially, he got the fascia from the rectus, brought it in, fixed it to the anterior, but he found that with every passing time, it became longer and longer because that fascia is not strong. So then he changed over to mesh. Now, we had Dr. Ajit Virkud, who was a student of both Purandare and Shirodkar. He combined both the techniques. He took one arm from posterior, attached it behind the uterus, one arm from anterior, and attached it in front. So you can see how these things have evolved, and it'll give you an idea that no one method's really working very well, so we had to do that. And then we have Dr. Sonawala, some of you would know him. Sonawala had a very simple option from the posterior sacral promontory, bring it to the back of the cervix. This is very similar to what we do today in repair. So all these methods were there. The Khanna sling, which is, Khanna was my late father's classmate in those days. Very simple repair, pick up. It was modified by Mangeshika for doing it laparoscopically. So in those days, this was a picture of nearly 20 years ago. Take the mesh, fix it vaginally. We don't do it this way at all now, but I just thought I'll show you what we've gone through. And then push the mesh inside, then go laparoscopically, pick up the mesh, and attach it to the lateral sides. So this was a very good thing, but we have given it up because we're really not happy with the supports. Our biggest problems was with the ports getting infected, and in some cases the lift was not enough. So these were the issues which we had to face. But we still have dilemma cases. This was as late as year before last this patient landed up. 32-year-old mother of one child, 2 years after delivery had a prolapse uterus, and for the delivery, they went to the doctor close by, somewhere in Maharashtra. They did a vaginal repair, problem recurred after 3 months, seen by another doctor who said we will do a perfect repair. So they repaired vaginally and they repaired laparoscopically. So they did the dual procedure. So vaginally did a Manchester, laparoscopically a sacrohysterocolpopexy. But sadly her problem continued. She continued being amenorrheic, and with cyclic pain, they dilated the cervix, gave GnRH, came with pain. We found a normal uterus. I'm sorry I can't show you all those pictures. With fluid in the uterine cavity, the cervical canal could not be traced. There was a gap between the cervix and the body of the uterus. We attempted hysteroscopy, didn't get anywhere. So what were the options which we had? Basically, you have a cervix, you have a body of the uterus above with fluid. That's my diagrammatic representation. We had to connect it. So we explained all the things. Finally, she got fed up. She said, I've got enough surgery, so I don't want reconnection, repair. Just remove the uterus. Sadly, at 32 years, we had to remove the uterus. So these are problems still occurring. Remember, when you're doing multiple procedures, be careful. Is there a need to operate every prolapse? Really no consensus between what you say normal, abnormal. More than half the multigravidas present with POPQ grade 2 disorders, and most often they are asymptomatic. In these cases, the decision about surgical treatment, if any, should be made with caution. And how do I choose my case? Go in detail. The age of the patient, extent of prolapse, state of health, comorbidities, most important, symptomatic or not. Then which method, which approach is something which you will have to decide, choice of the procedure also. So what are the aims of repair when we go? Remember, whenever you are repairing prolapse, you classify, quantify, rectify is a simple method. But the most important is that line in blue. Patient satisfaction after pelvic reconstructive surgery correlates with the achievement of self-described pre-operative surgical goals. So if the patient feels a little lump peeping out of the vagina, you do your repair, however wonderfully, if she finds it still after surgery, she will not be happy. So if you have done a wonderful repair from above, go below, do a small repair, push this little bulge inside, she'll feel very happy with that. So remember, you have to correct the anatomical defects, preserve organ function, pregnancy, if they want, improve symptoms, and lower the risk of recurrence. All these lists are very nice, but when you take it in a 3D view, it doesn't work out so. The queen very often doesn't agree to whatever repair you think of. So this is a big problem with prolapse. You can do does not mean should do. You have to think of each case separately. Several other newer techniques, pectopexy. You'll be happy to know that Vivek Joshi from Pune used to do pectopexy long before Gunther Noy developed the technique in Germany. Simple technique, take the mesh, anchor it behind the uterus, go to the pectineal ligament, take a bite on the pectineal ligament, both sides, and fit it there. Once you fix the mesh on both sides, you are creating like a hammock, and this is on one side, this is on the other side. The big advantage of this is that pectineal ligament really doesn't have too much vascularity or nerve structure close by. So you can take your bites boldly. Whereas earlier when we were doing the sacrocolpopexy, we were worried whenever we took the bite on the sacral ligament. So you take a bite, and then that's the picture. This is a post-hysterectomy case. And end of it, peritonize it. It becomes quite nice and clear. Works well, but sometimes we find there is a certain amount of defect. If you're doing it for a nulliparous prolapse, we may amputate the cervix from below to make sure that the repair works very well. Sacrohysteropexy today has come a long way. This is supposed to be the gold standard. You make a nick on that's on the sacral promontory. Go down. I showed you some of these things yesterday. So you can see you go right down. With today's imaging and today's hemostasis ability, the procedure is quite clean. See, that's the entire posterior peritoneum. We've opened, it's ready for the mesh. Then we go to the anterior surface. I mean, that's still posterior. So we take the mesh and in this case, we've just taken one mesh through the broad ligament on the right side, brought it anteriorly, and fixed the mesh. You can see our dissection becomes very clear, clean now. We know where we are, and we can. So I'm fixing the mesh anteriorly. So this is one. Yesterday, I'll show you that also, where you can take mesh from both sides if you want. So once it's well fixed anteriorly, then we go posteriorly, anchor it to the cervix posteriorly. And after doing that, so I'm taking 2 or 3 bites on the cervix. After doing that, go to the sacral promontory, and today we always suture it to the sacral promontory. I'll tell you why a little later. So once we suture it to the anterior longitudinal ligament, it holds well, works well. Procedure is reasonably clean. Cut off the redundant mesh, peritonize it, close it, and come. So these were the issues. So we would peritonize the whole thing. That's the peritonizing. And at the end of the procedure, you can see that the prolapse goes in reasonably well. It would go in at least another centimeter or 2 with time. So these were the things which you have to sort out when you're talking to the patient. This was the same thing with the mesh on both sides. I showed it to you yesterday. We make the mesh into a Y. Both sides make openings, go across, and anchor it anteriorly. So you see, this looks very simple because it fits very tight, both ends fit, and it works quite well like that. So this was what was termed as the Oxford technique. So sacrocolpohysteropexy is the gold standard for prolapse repair as of now. It's associated with the use of the uterosacral to strengthen it more if you want. Success rate is rated very high, but I don't think anything above 65, 70% is okay. With sacrohysteropexy today, we have variants also. We have the sacrocolpoperineopexy. Now, if you can figure out in this diagram, this is a sacral promontory. You take a mesh. Normally, we would fix it just to the apex of the wall. This is the vagina. But here you can dissect posterior to the vagina, go right up to the perineal body, and anchor it there. Some people say this works better, but today there's definite evidence from JMIG that such deep dissection may increase the risk of bladder, rectal injuries, as well as increase the possibility of mesh exposure. So you can see we are going through a lot of pros and cons. And as I said, this was a patient where we were doing a laparoscopic repair. But first, if needed, do a vaginal correction. Go up, your surgery becomes very much better. There are problems with the mesh. This was one of the problems we had. Sacrohysterocolpopexy done. Mesh fixed with tackers in those days. Patient had chronic back pain radiating to the right leg. And once that happened, she went to orthopedic surgeon, went here, there, everywhere. MRI done, showed a small collection of fluid around the tacks that were applied. We had to do a laparotomy, remove the tacks, and a bone graft had to be done for her. So after that, we don't use any more tackers. We just... So the question now is, should we do a hysterectomy at that time or not? So basically, the uterus says, save me at whatever cost. Now, if you go back on world literature, you'll see that in the years 1960 to 63, only 24% of prolapse repairs were combined with hysterectomy. But between 1978 and 1985, over 97% of cases, they did hysterectomy with that. So you'll wonder what happened in that period. The only period is that the thing is that the surgeons got more confident, and as the surgeons got more confident, everybody thought hysterectomy is child's play, just took it off. So that was what was happening. Now, the basic problem is, if you take the patient's analysis, 20% wanted hysterectomy, but 36% opposed it. They wanted to retain the uterus. And even in that 36%, 20% said, even if my repair is not good, please don't remove the uterus. So that brings us to the important thing. Why do they want to keep the uterus? Is it just physical integrity of the body? Fertility, of course, if it is there, we retain the uterus. There's no doubt about it. So this was analyzed further, where you see indications for concomitant hysterectomy, all the indications you are very familiar with. I don't have to go to. But a very interesting study of malignancy following surgery, following retaining the uterus, they found very, very little incidence of endometrial malignancy. This was a study from the International Journal of Urology, where they found just 1 in 501 patients. There's another study from Germany where there are about 600 cases followed up. Only they had 2 cases of endometrial malignancy. But we have to think of the possibility. Now, the important thing is the disadvantages of doing a hysterectomy. It takes longer time, yes. That's a big issue which we have to be worried about. But it exposes the mesh more. See, if there's the uterus there, it sort of covers the mesh and prevents it from getting exposed and works better that way. So that's again a problem which one has to think of. So the debate will keep going, whether you want to remove the uterus The doctor says, and the patient says, save my uterus. There is a big move in China with some of the surgeons there. They use the term of hysteropreservation versus hysterectomy. About 105 prolapse cases, half of them hysterectomy with uterosacral suspension. The other half, they did hysteropexy. That is basically uterosacral suspension without a hysterectomy. Now, they found there were no significant differences in the overall rates of recurrence of prolapse in both the groups. Subjective success rates were high in both. And the high uterosacral suspension they found was extremely effective in work. The other big advantage which is claimed, this is more by the urologists, they say that if you preserve the uterus, the incidence of post-operative urinary retention and bladder irritation is much less. They claim that the uterus possibly acts as a barrier in between those two things. What about if the uterus has already been removed and you have your post-hysterectomy wall prolapse? Here again, I told you the important thing is to get that apex well anchored. And here you have to be careful of mesh exposure and don't do anything about it. But even in this era, we get cases like this. This was a very unfortunate gynecologist who came from Calcutta, 76 years old, recurrent wall prolapse after 2 previous repairs of the defect. 2 normal deliveries, prolapse treated with Manchester, recurred after 4 years. So they did a vaginal hysterectomy, pelvic floor repair, and uterosacral suspension. Recurred after 1 year, they did a laparoscopic sling. She had urinary incontinence, discomfort, associated medical problems. She came to us with a big prolapse. So what to do? Discussed pros and cons. And in this case, surprisingly, what solved her problem was to do a colpoclysis. So even in this time and era, we have to think, if needed, we have to go for colpoclysis. Several other fancy new techniques are coming up. As I mentioned yesterday, laparoscopic uterosacral suture sacrohysteropexy. Basically, it's to take a thick suture from the sacral promontory to the back of the uterus and tie it, and like a sort of pulley, tighten the suture so the uterus goes up with that. So finally, how would you choose your repair and prolapse? You have the whole world open to you. Vaginal, laparoscopic, open, robotic, or you want to use it in combinations, whichever way you want. But my simple message to you is, choose one procedure, get familiar with it. Because you realize as you keep doing more and more prolapse, certain things you do heal well, take well, and this thing. Typical example as Professor Piley, you will see, over the years, he's developed and improved into these methods which work very well. So in conclusion, surgical repair of uterine prolapse is feasible, yes, no doubt about that. If you're thinking of doing laparoscopy, sacrohysteropexy appears to be the best option now. But we don't have really long-term results in RCT. But your success depends on good assessment, performing site-specific repair, see the defect and correct it, and solving the patient's problem. Solving the patient's problem. Concomitant hysterectomy you can think of. So this was a very interesting picture I saw. Before John Lennon made it cool, Harry Potter made it magical, and Steve Jobs made it intellectual. The father of our nation was the one man who started this trend. So in that theme, I think we must keep it simple and respect the needs of our patients. Thank you. Thank you, Jay Krishnan and Team 20.